We've broken the workshop tonight into different sections. The first section will be started by me, and then 3 of my partners will then present their respective portions. Second will be Dr. Lynn, who is one of our urology partners, followed by Dr. Pennycuff, who is another one of the urogynecologists, and then Dr. King, who is our colorectal partner. And then Dr. Giles will conclude the first portion of the event tonight, going out into the breakout rooms. And we can advance. So the Women's Pelvic Wellness Program at the University of Wisconsin is a very unique program where we have a multidisciplinary collaboration of all fellowship trained surgeons, physicians, and physical therapists who are working collaboratively to help women with an array of problems. We will hear from some of these folks tonight, as I mentioned, but the collaboration is in partnership between physical therapy, colorectal surgery, urology, urogynecology, and gastroenterology. And next slide, please. In order for us to really encompass the breadth of the disorders that we see most commonly, again, we're going to be addressing these specifically. So we're going to start with an introduction. We're going to do a couple little test questions, and then we're going to move into bladder issues, pelvic organ prolapse, then bowel issues. We'll share some additional resources. We'll have a brief time for questions and answers, and then we'll do the breakout rooms. So the first thing we're going to do to jump us off here is to ask a question of the attendees. So we're going to do a pop, no pun intended, quiz. So the first question is, as a woman, your chance of getting a pelvic floor disorder is it A, 1 in 3, B, 1 in 6, or C, 1 in 9? So you'll have a chance to take this quiz in just a moment. It's coming up. So you can go ahead and vote. We'll give a few seconds here for folks to vote. So a chance of getting a pelvic floor disorder, so a problem with bowels or bladder or prolapse, is A, 1 in 3, B, 1 in 6, or C, 1 in 9. All right, so the answers. So we have almost 80% saying 1 in 3. So we'll go ahead and close that out. And sorry, next slide. So it is 1 in 3 women will experience a pelvic floor disorder in her lifetime. So, you know, these are really common disorders that we manage. And so we do not classify them as normal, but they are very common. These are common conditions that women will present to us for care. And we'll take the next slide, please. So a question that patients will frequently ask is, well, what exactly is the pelvic floor? I mean, how do I, where is this part of my body? Well, the pelvic floor is a set of muscles, ligaments, and connective tissue that's in the lowest part of the pelvis. So this is the part that helps hold all of our internal organs in. So the pelvic floor supports the bladder. It supports the reproductive organs such as the uterus and the vagina. It also supports the rectum. And the pelvic floor is a grouping of these muscles, ligaments, and connective tissues that control pelvic organ functioning. So they're integral in eliminating urine and bowel movement, as well as with reproduction. Next slide, please. So women who have pelvic floor disorders may present with problems with their bladder or bowel that's due to weakened pelvic floor muscles or connective tissue that supports the pelvic floor. So patients may present with symptoms of urinary incontinence or having bladder leakage or bladder control. They may also come with symptoms of having to urinate really frequently, maybe saying, I gotta go all the time, or I can't hold back the urine. Once I feel like I have the urge to go, I start leaking. They also may have difficulty emptying the bladder. So they feel like they can't quite get all the urine out. They also may have trouble when they have an urge to have a bowel movement. They can't withstand that, and they may leak some stool. They also may have trouble getting their stool out. So they're constipated. And sometimes those conditions happen concomitantly. Patients may also present with pressure in their pelvis or in their vagina, or even the symptoms of vaginal bulging or something coming out of the vaginal opening. And patients may also have pelvic pain either with these symptoms or on their own. Next slide, please. So time for another pop quiz. So which of the following are risk factors for pelvic floor disorders? A, pregnancy, B, older age, C, being overweight, D, smoking, or E, all of the above. So you can go ahead and enter in your answer and we'll get those tallied. We'll wait a few more seconds for that. So which of the following are risk factors for pelvic floor disorders? Pregnancy, older age, being overweight, smoking, or all of the above? All right, we'll go to our next slide. So 100% of you said all of the above, which is exactly right. Now, some risk factors are within our control and some aren't. So things that we can control, I mean, obviously smoking is a choice, even though it may be hard to quit. So one lifestyle modification is not to start smoking, and if you do, to quit. Another is to maintain a normal weight, and being physically active is within most people's control. Also, being cautious with extreme sports. We hear very commonly from patients who might do some extreme sports. They maybe do parachute jumping, or they do, flipping tractor tires or something. So you want to be really careful with that kind of activity. Limiting caffeine and excess fluids can also be really important in managing this disorders and fully within choice, as well as avoiding constipation so that we're not straining and pushing down against the pelvic floor, which may actually exacerbate some of these conditions. Also maintaining good health, such as controlling blood sugar levels for patients who are diabetic, as well as keeping the pelvic floor healthy. However, things that are a little less controllable, we do know that our life stage, as we all mature, the risk of these disorders does increase with age. It also increases with pregnancy and childbirth. Other health conditions may play a role as well, such as pelvic injury or pelvic surgery. Any conditions that increase the pressure on the pelvic floor, including chronic coughing, like with chronic lung disease, also might not be fully within someone's control, but that can play a role as well. And then certain neurological problems. Next slide. So I believe that Dr. Lynn is up next to talk with us about urinary incontinence.
Thank you, Dr. Heisler. We're going to switch over to urinary incontinence, and in the US, 18 million women have urinary incontinence. And just some basic anatomy, this is sort of a cutaway view of the female pelvis, and the circle is really focusing on the important parts here, the bladder, the uterus, and just some other landmarks, including the pubic bone and where the bladder opening is, or the urethra, and then there's the vaginal opening. And sometimes there's some confusion, but the urethra and the vagina have separate openings. Just like any other parts of our bodies, the brain and spinal cord control the bladder and urinary functions. And this is a schematic of how that all works, but the bladder fills up and sends signals to our brain through our spinal cord and gives us the sensation of bladder fullness. And when it's appropriate timing, we can go to the bathroom and empty our bladders. And that's done through a bladder contraction with relaxation of the pelvic floor and the sphincter muscle. And when it all works perfectly, we are dry when we need to hold urine, and when we need to use the restroom, the bladder empties completely, ready for another cycle. Here's another pop quiz. So we'll bring up and this one's a little bit easier because it's true or false. Bladder problems only occur in women after menopause. Is this true or false? Everyone's going to get a chance to choose here. Dr. Pennycuff, is there a scoring sheet that's supposed to come up? Here we are. Looks like almost everyone got this correct. It's false. Bladder issues don't happen only after menopause. And so women of all ages can be affected, but it is more common as we get older, and up to 38% of those aged 80 or over can have urinary incontinence issues. And in the younger segment of 20 to 39 years old, 1 in 4 women, so it's about 25% in that group. And some of the risk factors include weight pressing on the pelvic floor, which can include pregnancy or being overweight, constipation issues, and then if you have a connective tissue disorder. And our diagram here just shows you a pregnant woman and some pressure on the bladder and how that can lead to incontinence issues. Here's another statistic, a little pie chart just looking at how long women wait to speak to their physician or care provider about urinary incontinence issues. Some women, 41%, seek care in about 1 year. Another third wait 1 to 5 years, and then some people wait over 5 years to seek assistance with this problem. And so we're here available for you guys to ask questions and seek help earlier rather than later. There's a couple of types of urinary incontinence. Starting from the left side, there's something called stress urinary incontinence, and this isn't when someone is actually having stress in their life, but it's actually speaking to urinary leakage with activity. This can be with coughing, lifting something heavy, sneezing. Some patients may note that they leak urine when they're running or doing anything sort of strenuous. There's another type of leakage called urgency incontinence, and this actually falls under the category of overactive bladder. And this relates to urgency. I've got to run to the bathroom. And if I don't get there in time, I might actually pee in my pants. Sometimes it's frequency or having to go more often than other people. You might note that, hey, I have to run to the bathroom twice as frequently as my friends or family. And then the last part of overactive bladder with urgency incontinence is the nighttime urinations. Gosh, I'm getting up to go to the bathroom a lot more than I used to, sometimes 3-4 times a night. And this can be really disruptive to our lives and getting poor sleep. The last category is other types, including mixed urinary incontinence. We can have both types of incontinence, including stress and urgency incontinence. And then there's other categories, including a continuous incontinence that is less frequently found. Here's another pop quiz. Here's an easy one, 50-50 shot. Making changes to your diet may help control urinary incontinence. Is this true or false? Here's another quiz. Let's see what everyone says here. Well, 88% of people said that's true, and it is true. Dietary changes and fluid intake changes can definitely help control urinary incontinence. So what can patients do? Well, there's lifestyle changes. One of the big ones is losing weight if you're overweight, limiting things like alcohol and caffeine, which can have a diuretic effect, or our bodies may want to make more urine quicker. Avoiding excess fluid intake, so avoiding fluid intake prior to bed several hours so that we don't get up in the middle of the night, and then avoiding constipation. A bladder diary can be very helpful to track how often we're actually going. Sometimes we actually think we're going more frequently than we need to, and that can really give us some perspective on how often we're actually going. And then trying to schedule bathroom trips and to prevent leakage issues. This is sometimes called timed voiding. Treatments. So healthcare providers may recommend lifestyle changes, which we just briefly discussed, a bladder diary to get a sense of how bad the leakage is and how often we're going to the restroom. One of the mainstays in pelvic floor dysfunction is pelvic muscle exercises, which sometimes is referred to as Kegel exercises. These can also be done with physical therapists that are experts in helping us relax and strengthen our pelvic floor. There are other options for different types of urinary incontinence, and sometimes we need to have multiple types of treatments. But every individual is different, and so we tailor our treatment options to what works best for you. We don't have a set treatment protocol that is a rubber stamp deal for your friend or sister, but we try to individualize it so that you have the best outcome for your life. One of the treatments for overactive bladder, which we talked about briefly, was bladder training, behavioral changes, and then also physical therapy. There are medications that we can take that can relax the bladder muscle so that it doesn't squeeze inappropriately. And we usually try at least 2 of these before we move on to advanced treatments. Advanced treatments include a nerve stimulation, sometimes called an acupuncture for the bladder, done through the ankle. There's also Botox injections for the bladder muscle. And the last option is something called a pacemaker for the pelvic floor, sometimes called InterStim. We can also use these in all combinations to help you with your symptom control. Some options for stress urinary incontinence, again, are behavioral changes and physical therapy. There's also something called the pessary. We'll talk about this more in the breakout session for stress urinary incontinence, but these are devices that go inside the vagina to help support the bladder and urethra, and they can prevent leakage. The diagram sort of shows how those are positioned inside the pelvis and the support that it gives to the bladder and the urethra in that location. Advanced treatments include urethral bulking injections and sling surgeries using mesh and without mesh, and these are considered advanced treatments that are more surgical in nature.
All right, Dr. Lin, thank you so much for that overview of urinary incontinence. I think that this is where I come in to talk a little bit about pelvic organ prolapse. I'm Dr. Jon Pennycuff. I'm one of the urogynecologists at the University of Wisconsin. And pelvic organ prolapse is very common. About half of women over 40 will have some form of pelvic organ prolapse. And so what exactly is that? Well, during the lifetime, the pelvic floor muscles and the ligaments become stretched or weakened, and they can no longer hold the organs, the pelvic organs like the bladder, the uterus and vagina, or the rectum into the correct position in the pelvis. And women may, as it progresses, they may not notice anything, and then over time, they may begin to feel bulging coming out of the opening of the vagina. When it's the bladder that's falling, we call it a cystocele. And when it's the rectum that's falling, we call it a rectocele. And then also the uterus can drop, called uterine prolapse. People worry that their bladder is going to fall out, or their rectum is going to fall out. And actually, it's just these organs pushing against the vagina. So the bulge that women feel is the vaginal wall, and nothing will actually fall out, but it's that sense of bulging that women often come to us experiencing. So women who have pelvic organ prolapse will experience symptoms like pelvic discomfort. They may feel pressure or heaviness, especially with walking, exercise, standing at the end of the day. They may actually feel a bulge or a lump in the vagina and see something coming out. And a lot of women worry that this is something really scary or dangerous, life-threatening. They may have a difficult time emptying their bladder. They feel that it's hard to start their stream, or that they don't empty completely. They may even need to push in or around the vagina in order to feel like they've emptied their bladder completely. And the same is true for bowel symptoms. They may feel like they have to really strain to have a bowel movement, or they may have to push in or around the vagina as well to help the bowel movement come out completely. And some women will even feel like, oh, I feel like I never really have a complete bowel movement and I feel something stuck. So the good thing to know is that pelvic organ prolapse is not dangerous, it's not cancer, it's not life-threatening. And so the treatment really depends on how much it bothers you and what your goals of care are and how you want to proceed. So what we want to do is improve your quality of life, improve your day-to-day activities, and then also improve your sexual health. So some women just want to know what's going on. And once they know, they say, you know what, it doesn't bother me that much. I wanted to know what was going on, and now we can just watch and wait. Some women want to do a little bit more conservative therapy, like pelvic floor muscle exercises or physical therapy. And some women want to do a pessary, which is sort of a plastic, as Dr. Lin described, is a plastic disc, a silicone disc, much like a cervical diaphragm, that's inserted into the vagina to help support the bladder, the uterus, or the vagina. There are also surgical options for women who want more definitive management. And our goals are always to figure out what is right for the patient in front of us and what her goals of care are and what she wants to accomplish with surgery. But ultimately, we want to restore function. We want to reduce the bulge and overall improve her quality of life. So no single surgery is right for every woman. And so we talk to you about the options for surgical management, and we kind of get a sense of what are your goals, what are you hoping to accomplish, what's going on with your body and your anatomy. Maybe you have some other health conditions we have to take into considerations. Maybe you've had some prior surgeries. Maybe you want to be able to be sexually active in the future. Maybe you don't. And that can help guide us in our treatment options. And then also you want to make sure that your surgeon is experienced and trained to perform the surgeries that she or he best can offer you for surgical management of pelvic organ prolapse. And success or failure of someone else's operation shouldn't be the deciding factor. We have a big group of doctors who are ready to talk with you about what your goals of care are and how we can best help you at Women's Pelvic Wellness Clinic. So to finish up with the quiz of my portion, the question is living with pelvic floor disorders a normal part of aging? Yes or no? All right. And the answer is no. While pelvic floor disorders are very common, they're not really part of normal aging. And there are doctors and physical therapists and nurse practitioners who are ready to see patients and help guide care plans that best meet your needs. So with that, I'm going to hand it over to Dr. King, who's going to talk a little bit about bowel control.
All right, can we have the next slide, please? Hi there, my name is Ray King. I'm a colorectal surgeon at University of Wisconsin-Madison, and I operate primarily out of Meriter Hospital, but I also have our clinic with the rest of these folks at the Women's Pelvic Floor Clinic in Meriter. So I'm going to talk about the part that nobody likes to talk about, which is basically bowel control. And this is certainly something that most people don't like to talk about. So what we see that, 15 million women over the age of 40 experience some sort of accidental bowel leakage. That can mean a lot of things. And we're thinking about bowel leakage, we're talking three different things. We're thinking gas, we're thinking liquid bowel movements, and we're also thinking full on solid bowel movement leakage. 1 in 5, 20% occasional, maybe once a week, once every, twice a week. 1 in 12, once a month, and then 1 in 30 every week. So, and really, I think it's a lot more than less than 30%. I think it's actually a lot less than 30%. Most people don't really like to talk about it. When I was in private practice in the South in Georgia, this is something that people just assume that happened to everyone. My mama had it, her mama had it, and this is something we just dealt with. But then most people don't like to bring it up out of, something that we're kind of used to not talking in polite society. But believe it or not, a lot of people experience this. Next slide, please. So, right, you're not alone. Really, you're not. And we see this all the time. Bowel control problems, it's embarrassing. It really is a quality of life issue. And it's something that certainly affects your social life, your sexual life, just in terms of, it's something that you thought you had control over and all of a sudden you don't, and is embarrassing. Certainly, this is something that you should not be embarrassed about or ashamed to talk with your doctor, particularly with somebody who is a specialist in this area. And also with somebody who hears about this all the time. And we know all the different variations and permutations and causes and effect and all those things. So feel free to talk to us about all of that. It can be related to a medical problem. It could be something as serious as something like Crohn's disease or ulcerative colitis or even cancer. However, majority of the time what we see that these are really related to the pelvic floor and also your dietary habits. These problems can be controlled and it can be treated with various different options, like my colleagues have talked about in the previous slides with the urinary aspect. On the bowel control aspect, we're not dealing with just the bladder and the pelvic floor. We're dealing with your entire GI tract from your mouth all the way down to your rectum and anus. So, but there are a lot of things we can do to control this. So really feel free to talk to me about this because it's something I talk about all the time. Next slide, please. So how does it work? So they're basically just like the muscles in the anterior or the front portions of your pelvic floor. There are sphincter muscles on the bottom of your GI tract, namely your anal sphincters. And these muscles basically hold stool. And we have this amazing ability to actually let you know when the rectum is full. So your rectum, like the bladder, is a reservoir. So when there's stool that comes down through your GI tract, through your large and small intestine into your large intestine, and everything gets absorbed and resorbed, when it gets into your rectum, it actually fills it up and it stretches your rectum out to a point where it hits a threshold, and it tells, and those nerves tell your brain that, hey, it's time for you to, go have a bowel movement or go poop. But, and over time, we've basically trained ourselves to have these social cues on when is it appropriate to go to the bathroom, when is it appropriate to, let out some gas, when you're in the elevator by yourself, when you're like, all right, it's not so bad, or when to actually hold it, right? So you have that sense of control. And what's really amazing is that during that process, your body is actually able to tell. We have this reflex. When the rectum gets distended and gets filled up to that point, we actually have what's called a sampling reflex, where it actually samples what's in your rectum. So is it gas? Is it liquid? Is it stool? So you can tell. And most of you right now listening can actually hopefully have that sensation of like, okay, I think this is just as gas. Or sometimes you can't tell, and that's where the problem occurs. So, and when it's socially appropriate, a lot of times it signals you and you're like, okay, it's time. It's appropriate to go to the bathroom, or it's appropriate to let out some gas, and that's when everything relaxes and you're able to have a bowel movement. So the pelvic floor nerves and the muscles kind of work in this synchronous fashion to allow you to have, one, the sensation, two, the reflex to realize whether or not you can go or it's appropriate to go, and then three, actually the function of having a bowel movement. All right, next slide, please. So what are we seeing? We see a lot of accidental loss of gas and or liquids or solid bowel function. And that's a really big thing for me to see if it's something that we need to, how aggressive we need to be in terms of treatments. Now, one thing we definitely see a lot is chronic constipation. All right. So basically about 5 to 6 million people in the US experience chronic constipation. And that's not just once in a while. With chronic constipation, we're talking about something that we experienced over the last 6 months or more. So what does that mean? That means fewer than 2 bowel movements per week. Your stool is hard, dry, like little rabbit turds, small and difficult to evacuate. You're sitting on the toilet for 15, 20, 30 minutes straining, or you feel like whatever you're pushing out is not enough. So you have to try it again over and over again. I have patients that, spend 2, 3, 4 hours a day trying to have bowel movements. A lot of times with pain with bowel movements, or the opposite of diarrhea, loose, watery bowel movements. you're passing, loose stools 3 or 4 or 5, 10 times a day. And with multiple days in a row, that may actually prompt an evaluation of something else going on besides just diarrhea. Next slide, please. So, when you come to see me in clinic, the first thing I would ask you is, what are you eating, right? Because input and output is pretty, it fits. So what exactly are you eating? For chronic constipation, for diarrhea, difficulty with defecation, the first thing we would say is increasing your fiber intake. We recommend 20 to 25, sometimes even 30 grams of fiber a day. And I know that's a lot. What we a typical American diet right now, I would say for most of us in this talk and most of us on this panel, I would say our fiber intake is averaging probably 1 to 2 grams a day. So we're looking at maybe 10% what we really need. So a lot of times what happens is people hear about this and they go out and buy a big old jar of Metamucil or whatever, and they take whatever is recommended on the bottle, which is 2 heaping tablespoons. What that would do is that it would actually make you very gassy and bloated, and you won't want to continue. So we certainly recommend starting low dose, starting very gradual, maybe 1 or 2 teaspoons a day, and then do that for about a month and see how your body adjusts to it. What fiber does is that it actually is a great regulator where it helps with both constipation and diarrhea. The fiber itself actually acts like a sponge, and what it does is that it soaks up a lot of fluids and it actually makes your stool bulky. So it gets rid of diarrhea and also helps with constipation. And it actually helps your body, helps your colon to actually pass that stool from one end to the other. Now, in order for fiber to work, it actually has to work with water, because if you just take fiber and don't drink anything, you're basically making bricks. So what you need to do is drink probably about 2 to 3 liters a day. Now, the problem with that, going back to what my other colleagues were talking about, is if you drink 2 or 3 liters a day and you have urinary incontinence, and that can be problematic. So that's something that we certainly have to talk about and come up with a plan for. Now, for accidental bowel leakage, there are a number of things, and this is one of those funny things I always talk about, is that certain foods and certain drinks, in fact, all the good stuff, actually can make some relaxation of your internal anal sphincter. Coffee, wine, chocolate, and spicy foods. Those things, typically what happens will cause a relaxation of your sphincter muscle, and whatever mucus or anything else that's at the end of the rectum can't seep out because of that relaxation of the sphincter muscle. And that may present as some just what we call pruritus ani, which is basically just a lot of itchiness and irritation around the anal area. For constipation, a lot of things like starch, rice, bread, pasta, cheese. I know in Wisconsin, we eat a lot of cheese. So a lot of those things can cause constipation. So most of what we talk about from a initial consultation is really thinking about what you're putting in. Next slide, please. Now, medicines. Well, how can we treat it? I get this a lot, and there's a lot of confusion between laxatives, fibers, and stool softeners. So stool softeners, typically what they do is they actually draw in fluid. So you're talking about things like Senecot, things like Colace. Those are what we typically call generically stool softeners. They work by various different ways, one of which is basically irritating the lining of the colon, so they secrete more fluid to make things go. Laxatives, things like Miralax, Dulcolax, do that precisely. Most of them function by, you're talking about things like Miralax, Dulcolax, milk of magnesium, or magnesium citrate. Those things actually have this effect where they draw in a ton of fluid through osmotic gradient, and that extra fluid can actually push out whatever's in your colon. The problem with laxatives is that they will make your bowel movement very liquidy and watery, and especially if you have a little bit of less control of your sphincter muscles, those fluidy or watery bowel movements can actually make things worse. Now, antidiarrheals, we're thinking about something like Lomodal, or those things are the ones that keeps you from going, which means if you're having a couple days of diarrhea, a lot of times people take something like Lomodal to kind of stop things from going. Now, The problem with that is if there is a infectious cause of diarrhea, or if there's a cause that like Crohn's disease or something else, taking those things may not be a good idea. Now, what else can we do? Now, my colleagues have mentioned physical therapy, and that's something we certainly will, because we're all functioning off the same pelvic floor. Pelvic floor PT is actually very helpful to strengthen some of your sphincter muscles, especially from the colorectal side. One of the things we talk about is inability to poop, in the sense that where you're basically almost pooping against yourself. And that is more of an issue, what we call obstructive defecation, where a muscle in your pelvic floor is contracting when it should be relaxing when you're bearing down. And when that happens, one of the modalities that physical therapy can offer is called biofeedback. So those are the things that we can certainly discuss when we see each other in the office. Next slide, please. All right, and that's it. All right, I'm going to pass this on to Dr. Giles.
All right, thank you, Dr. King. Dr. Pennycuff, you can go to the next slide. And one more. All right, so I'm going to wrap up some of what our speakers started talking to you about. Hopefully everybody understands that pelvic floor disorders are not a normal part of aging. They are very common, but not a normal thing. And another thing to realize is that people can suffer from one or more pelvic floor disorders. So you could have urinary incontinence as well as prolapse, or urinary incontinence and prolapse and fecal incontinence. So it is a wide spectrum. Next slide. So hopefully everybody understands also that you're not alone. There are resources out there. This is one of our favorite websites to go to. It's www.voicesforpfd.org. And this has great support sites. It has handouts, and it also has stories from patients themselves who talk about this, so you can gather more information. So again, Voices for PFD. They also are on Twitter and Facebook for you to connect and talk to people. Next slide. Here are some other online resources. Again, the Voices for PFD, www.yourpelvicfloor.org, some Medline pluses, and as well as the National Continence Foundation. Next slide. One other thing that we're talking about here is pelvic floor physical therapy. You've seen a theme with urinary incontinence, pelvic floor prolapse, and fecal incontinence, that pelvic floor physical therapy is very beneficial. It is a non-surgical option that may improve your symptoms. And luckily in Madison, there are several specially trained physical therapists who specialize in the pelvic floor, both also at UW Health in our clinic, as well as Meriter, GHC, and Capital Physical Therapy. So there are a lot of resources out there for patients with all the different insurance companies. Next slide. This is a kind of a picture of some of us. Again, we work at the Women's Pelvic Wellness Clinic, which is inside of Meriter Hospital. And it is a group of us of the urology, urogynecology, colorectal surgery, gastroenterology, pelvic floor physical therapist. We also have our nurse practitioner colleagues who are specialists with the pessaries that you heard about, as well as some of the non-surgical options. Next slide. Okay, we're going to go to the M, who's going to show a short video of what our clinic actually looks like. All right, M. All right, there's no sound, so I'm going to just go live. This is the entrance to our clinic here. When you come in, this is our schedulers who check our patients in. When you leave, they're also the ones who will check you out and help arrange follow-up or testing and such. And around the side of that is our waiting room with the appropriate spacing. This is one of our special rooms where we do a test called urodynamics with special chair and special machines. We have bathrooms everywhere in our clinic, so you can leave a urine sample or go to the bathroom. And this is one of our typical exam rooms right here where we will be seated there. We'll do the exam on that table. And again, a lot of bathrooms in our clinic. Our nurses are very important. And here are a couple of our nurses in our clinic. So they help answer questions, help with scheduling. And here is one of our pelvic floor physical therapists and one of her rooms. So we have special bed to help with that. Thank you, Em.